The next is mucocele and empyema. What is mucocele? See, suppose this is the gallbladder. If a stone is blocking here in the cystic duct, so what happens to the bile secretion? What happens to the gallbladder secretions?
It gets entrapped inside the gallbladder.
It keeps on accumulating and it distends. That is mucocele. That is mucocele of the gallbladder. If this gets infected, that becomes empyema of the gallbladder. Empyema. Okay, one is just distension of normal secretions and the other is empyema. Okay, infection is empyema. And in this connection, okay, so see here, stone location A, stone location B, and stone location C. Which of these stones can cause jaundice? All three, either only two, one. Abstract to jaundice, I mean, abstract to jaundice.
B.
B.
B and C.
Should be C.
Yeah, and
B also.
B will not cause abstract to jaundice because only the gallbladder secretions are blocked. Okay, but the liver secretions are there. Right? Liver secretions are normally going into the duodenum. So A will cause jaundice, abstract to jaundice, and C will cause abstract to jaundice, but not B. So what are these stones called? A and C. They are in the duct, so they have a special name for it. What are those? Polydoco. Yeah, this is stones in the gallbladder is cholelithiasis. Cholelithiasis. Here it is cholelithiasis. Okay, stones in the main common hepatic duct or common bile duct. They will cause jaundice. Okay, not the stone in the cystic duct. Cystic duct will not cause jaundice. Okay, you're getting my point?
Yes, sir.
Okay.
So A and C are
Cholelithiasis, yes.
lithiasis, and B is
Cholelithiasis, and B is cholelithiasis. So, but there is a special entity called Mirige's syndrome. Heard before of this? Heard? Not heard? Mirige's syndrome.
Heard of it, sir.
Heard of it. Okay. So this is a special entity where there is a stone in the cystic duct, but what happens is there will be surrounding inflammation will be there. This all will be inflamed, and because of this inflammation, the patient will present with jaundice. Because of this inflammation, this gets obstructed. The common bile duct will get obstructed. The hepatic duct will get obstructed, and so the patient will present with jaundice. This is the only stone which is present in the cystic duct, but the patient will present jaundice. Remember, okay, this is that syndrome is known as Mirige's syndrome. Mirige. Okay, so this occurs during for impacted gallstones in the cystic duct. See here, there is an impacted gallstone cystic duct, which is causing compression, indirect compression on the hepatic duct. Are you able to see that picture clearly? It is very clear in this. Yes?
Yes, sir.
Here, there is a stone in the cystic duct, which is blocking in the cystic duct, which is indirectly causing pressure on the bile duct. Yes, no?
Yes, sir.
Okay, this is Mirige's syndrome. So the investigation of choice is MRCP. What is MRCP?
Magnetic resonance cholangiopancreatography.
Magnetic resonance cholangiopancreatography. Study of cholangiopancreatoducts with the help of magnetic resonance. Okay, so that is that. And then management is do a lap cholecystectomy. Just doing a lap cholecystectomy will be enough. You remove the bladder, you remove the common gallbladder along with the cystic duct. You remove till here. Okay, then it's enough. So treatment for Meiji syndrome is simple lap cholecystectomy only. Okay.
Okay, sir.
So this is cholecystoduodenal fistula. What is cholecystoduodenal fistula is, this is the gallbladder and this is the duodenum. Sometimes there will be a fistula formation. I told you meningitis is stone is blocked here and it is causing inflammation here. Sometimes what happens, stones, because of stones and inflammation in the gallbladder, there will be fistula formation between the gallbladder and the duodenum. So stones come into the duodenum. Okay. So we see what is known as small bowel obstruction. Because of stones, there may be obstruction. There may be ileus, gallstone ileus, and there may be pneumobilia. There will be gas in the biliary tract because these duodenal contents will go into the biliary system. So normally there will be no gas, but here there will be gas in the biliary system. This is a triad again. Okay, pneumobilia is there, small bowel obstruction is there, and gallstone ileus is there. So this is the classical picture of cholecystoduodenal fistula. Cholecystoduodenal fistula. And now coming to choledocholithiasis. What is choledocholithiasis?
Formation of stones in the duct.
In the bile duct or common
Bile duct
hepatitis.
or the
Bile
common.
duct or common hepatitis. Anywhere in this channel, if it is there, it is Charcot's triad. Charcot's triad, it is PJF. Pain will be there. Pain will be there.
Jaundice and
will
fever.
be there. And fever will be there. And what is Murphy's triad?
Is it PVF, sir?
Yeah, it is PVF. Very good. So Murphy's
Pain,
triad is
vomiting, and
pain, vomiting, and fever.
fever.
Here it is pain, jaundice, and fever. Okay, it is Charcot's triad. Charcot's triad. It is the classic of choledocholithiasis. See, a young male comes to you with pain, right upper quadrant pain. On examination, he has jaundice also. He has fever also. Then no doubt he is having a stone in the biliary tree, main tray. That is in the hepatic duct or in the bile duct, not in the cystic duct. Okay. Make sure you should be well versed with that. Not in the cystic duct. Cystic duct is nowhere concerned with jaundice. Clear?
Okay,
Yes,
sir.
sir.
Yeah. So, and these patients will have septic shock and altered mental status also. If they have this septic shock and altered mental status, it becomes a not a triad, it becomes a pentad. It is known as Reynolds pentad. Reynolds pentad. Reynolds pentad. Okay. So, along with PJF, pain, jaundice, and fever, the patient will have septic shock and altered mental status. If these five are there, then it is known as Reynolds pentad. Okay. So the investigation of choice is MRCP again. You do a magnetic resonance cholangiopancreatography. For meningitis also it is MRCP. For choledocholithiasis also is MRCP. For tiny structures, CT will not be so much effective. So it is better to do a MRCP. Okay.
Okay, sir.
Yeah. And treatment. So you should tell me the treatment. What can be done best?
Bypassing.
Yeah, tell me the options. Stone is here, it is blocking. Think of various methods.
So can we do cholecystectomy?
ERCP?
Yeah, cholecystectomy, you will remove till here only, right? This gallbladder is removed, cystic duct is removed. Only till here it is removed.
Can we break the stones like lithotripsy, something like that?
Yeah. So we do a ERCP. It is a minimal invasive technique, ERCP. Endoscopic retrograde cholangiopancreatography. We put a scope inside the mouth. We'll go into the stomach, into the duodenum, and from here we open it. We open the sphincter of OT. Through the sphincter of OT, we go inside and we will. Most of the times these are very small stones, tiny stones. We can just bring it out, or we will put a stent here, small biliary stent here. Okay. So the treatment is ERCP. Okay, that is one option. And ERCP, it is not guaranteed surgery. It is not a guarantee procedure. It may fail. If it fails, you will do a lap CBD exploration, laparoscopic CBD exploration, we call it as CBD exploration. We open the CBD, we just make an incision, take the stone and suture it, or open CBD exploration. Okay, so three techniques. One is ERCP and stone removal, or lap CBD exploration, or open CBD exploration. Okay,
Stenting, sir.
which one?
Can we make that? I mean, can we make a note of it? No, stenting, biliary
Yeah,
stenting.
ERCP with stone removal and stenting. All these three go hand
Okay.
in hand.
Okay, so it's a part of it.
Yeah, part of it.
Okay.
Okay. This is about choledocholithiasis. And after that, this stone, where did the stone form? The stone formed in the gallbladder only, and it has rolled down. Okay. The stone formed in the gallbladder and it has rolled down here. Okay. So we have to do after this procedure is over, what we have to do? We have to do a cholecystectomy to prevent recurrence. Okay. And if the stone is here, then whatever features I told you, PJF, pain, jaundice, and fever. If the stone will dilk further, and if it blocks here, what will happen? Morning we discussed. There is pancreas here. The stone is getting blocked.
Something like necrosis of the pancreas.
Yeah. What?
Obstruction.
Obstruction will lead to acute pancreatitis. Yeah.
Okay.
Okay. And this is an image-based question for you. This is a teat tube. We call it as a teat tube. Okay, teat tube it is known as teat tube. See, whenever you do a open or lap CBD exploration, this is the CBD, this is the cystic duct, this is gallbladder removed here, this is the gallbladder, it removed. And whenever you open it, if we close it, it will stricture on itself. So what we do is we put a teat tube here. Okay, so it has two arms, one in the proximal and one in the distal, and it is communicating to the outside also. So what we do is after 14 days, we give a dye through it. After 14 days, we give a dye through it, and we will just take a picture whether it is dry, is free flowing into the duodenum or not. Okay, if it is free flowing, then there is no stricture. Then we can remove the teat tube. This technique is known as teat tube. Anybody? Teat tube? It is a dye technique. We are just teat tube. No, it's a technique to check whether the patency is there or not. What is angiogram? Angiogram.
So you're asking what is an angiogram?
Yeah, what is angiogram? Yeah.
Studies the blood vessels, right?
Yeah, it studies the blood vessel by giving a dye. In the same way, here, remember, it is teat tube cholangiogram.
Okay, yeah.
We are studying the ducts here. Okay, so it is known as teat tube. Via teat tube, we are giving the dye. Okay, so it is known as teat tube cholangiogram. Okay, is it okay?
Clear, sir.
Yeah. So this teat tube we have to remember. Only two tubes. Riles tube I will show you next, and this is teat tube. Okay, lap cholecystectomy, laparoscopic cholecystectomy. The most common complication is right shoulder pain, because you are distending the abdomen with pneumoperitoneum. Due to the referred pain, the right shoulder tip pain will be most commonly seen. Okay, and there are two techniques. One is fundus first. Suppose this is the gallbladder, this is the cystic duct. You can start operating from here. This is the fundus of the gallbladder, or this is the Calot's triangle. You can start operating from here. So there are two techniques: fundus first and Calot's first. Okay, fundus first. First we will tackle this fundus, and then we will move on to the Calot's. Other is Calot's first. First we will tackle with the Calot's and move on to the fundus. Okay. Clear?
Yes, sir.
Yeah. And what is the most common bile leak after lap chole? See what happens is, you have removed from here. Okay, this part is not there now. So now it is looking like something like this. You have sutured it here, isn't it? Yes?
Yes, sir.
So what happens is, most common bile leak after lap coli. It will leak from here only. This bile coming from the liver may leak here. So it is a cystic duct. It is known as the cystic duct stump. The remnant is cystic duct stump. Okay, the stump may leak. That is the most common complication, most common bile leak. Okay, and long-term complication is the duct may stricture here. It may stricture because of your surgery. There may be chance of stricture. This is a long-term complication. Okay, and there is a
But so we have removed the gallbladder, right?
yeah, we have removed the gallbladder.
The leak is actually hepatic juice. Then.
Yeah, from bile is coming from hepatic.
The
From
leak
the
is
liver
actually
only.
hepatic juice.
Yeah, it will come from the liver, get stored in the bladder, gallbladder, and it will be occasionally it will be released into the duodenum. Isn't it?
Yes.
So if you do a lap coli, there is always chance that the bile may leak from here. Okay, that is one, and there is always chance that you are operating in this field. You are operating here. This is your site of operation. So you may injure this duct, you may injure this duct, you may injure this duct. Okay. So bile duct injury is the most common complication after lap coli. So what is the classification for that is Strasberg has given a classification, Strasberg classification of bile duct injuries. Okay. No need to go into depth of it, but just remember Strasberg classification. Okay. What is the classification for hydrated cyst? Liver hydrated cyst? Come on. Starting with G.
Garbi.
RB. Gross is yesterday, tracheoesophageal fistula. Here, bile duct injury is Strasberg. Remember these three things: Gross, Garbi, and Strasberg. Bile duct injury is Strasberg. Okay. And then we'll move on to gallbladder cancer. What are the risk factors for gallbladder cancer? Gallstones, yes. Gallbladder polyp, yes. And porcelain gallbladder. What is this porcelain gallbladder?
Calcification.
Calcified gallbladder. Very good. Morning I have showed you the picture, right? About this. This is the porcelain gallbladder. Okay. So the gallbladder is calcified. This is a pre-malignant condition. So in previous exam, the question was, what are the risk factors for gallbladder cancer? Except all the following are risk factors for gallbladder cancer. Except that was the question. Except. So option 1 is gallstone, 2 is polyp, 3 is porcelain gallbladder, and 4 is cholesterosis. So the answer is cholesterosis. So what is this answer is? Cholesterosis is nothing but it is strawberry gallbladder. Strawberry gallbladder. See here, you can see this. Yes. The gallbladder will be studded with small microvasculature, which is known as the picture is almost similar to like a strawberry. Are you able to identify it?
Yes.
This strawberry gallbladder is not
gallbladder.
Sorry?
Not a pre-malignant condition.
It's not a pre-malignant condition. Yes. So this question was there. Options are these 4 options were there. So gallstones, yes. Gallbladder polyp, yes. Porcelain gallbladder, yes. Strawberry gallbladder,
no.
no. Okay. So then if we move on, investigation of choice, CECT again, staging PET-CT. The tumor marker is CA19-9. What is the tumor marker for HCC?
Alpha fetoprotein.
AFP.
What is the tumor marker for fibrolamellar variety of HCC? Starts with N.
NET.
Neurotensin?
Neurotensin
Yes,
B.
no? Neurotensin B, very good. Okay, and then finally the tumor marker for gallbladder cancer. This is the last tumor marker. Tumor marker for gallbladder cancer is CA19-9. 19-9. Okay, and the most important prognostic factor is T stage and depth. Okay, the T stage and depth are the most important. So these are the 4 points here. So investigation of choice is CECT, staging is PET, tumor marker is CA19-9, and important is T stage and depth. So coming to almost the last topic, polydocal cyst. Heard about it before? Yes, no?
Yes, sir.
Yes, sir.
What is this? What is the polydocal cyst known as? What is that basically?
Cyst in the common bile duct.
So, isn't it a birth defect?
Yeah, it's a
Congenital
congenital defect.
condition?
Yeah, congenital condition. Okay. So here, this is the biliary tree. We call it as the biliary tree. This whole thing, isn't it? This is the biliary tree. So cyst anywhere in the biliary tree is known as choledochal cyst. Cyst is the congenital cyst. That is congenital dilatation of the biliary tree is known as choledochal cyst. Okay. Based on the types where it will occur, it may occur here only. It may occur the entire tract. It may occur in the duodenum. So based on it, there are 5 types of, again types came. 5 types of choledochal cysts are there. So we'll see what are those types. So see here. So you should tell me. This is the gallbladder. So what is this? Type 1. What is the type 1?
Sir, can you repeat it once?
Sorry?
Can you repeat it once, sir?
Yeah. Choledochal cyst is nothing but it's a congenital malformation. It is congenital malformation of the biliary tree. First point. Second is it presents with a dilatation of the biliary tree. Some part of the biliary tree is dilated. Depending upon the type, depending on the part where it is dilated, there is a classification for it. Class 1, 2, 3, 4, 5. Okay. So type 1. So this is the gallbladder. This one, this pink one is the gallbladder. So this is the right hepatic duct, left hepatic duct, common hepatic duct, bile duct. The bile duct is dilated here. Okay, this is type 1. So to describe it, I'll describe it as fusiform dilatation, fusiform dilatation of extrahepatic biliary tree. It is extrahepatic, right? See, this is intrahepatic means within the liver. It is extrahepatic. Fusiform dilatation of extrahepatic biliary tree, bile duct. Okay, this is type 1. Agree?
Yes, sir.
So what is type 2? See here. This is the gallbladder. What it is like? Tell something. Even if it is wrong, it's okay. You'll remember next time.
Like a diverticular there.
Excellent. So first is extrahepatic dilatation. Second is a small diverticulum. Diverticulum. It is a small diverticulum here. And third is, see, it is almost at the tip. So this is the duodenum. Okay, it is within the duodenum, inside the duodenum. Okay, this is known as a polydocoduodenocele. Polydocoduodenocele. That is type 3. Polydocoduodenocele. And what is this? Type 4?
Sir, can you repeat the type 2, sir?
Yeah, type 2 is having a small diverticulum. Extrahepatic, it is having a very small diverticulum of the biliary tree. Okay?
So
And
small diverticulum of extrahepatic biliary tree.
biliary tree. Yeah, here type 4A is, it is having both intrahepatic, extrahepatic dilatation. Intrahepatic is dilated, extrahepatic is dilated. Okay? Yes?
Yes, sir.
Type 4B, it is only extrahepatic but multiple. It is almost similar to 1, but it is having multiple things. Okay, multiple dilatations, extrahepatic. It is a single dilatation, 1 is. It is having multiple dilatations, 4B. And type 5 is only intrahepatic. Within the lungs, within the liver only, there is dilatations. Okay?
Sir, type 5, type 4B and type 5, sir.
Yeah. 1 minute. I will just draw here so that. So basically, you should know what is normal anatomy. This is the gallbladder. What is this coming? Tell with me, what is this?
Cystic duct.
Cystic duct.
All of you,
Cystic duct.
what is this?
duct, sir.
Right hepatic duct.
Right
Hepatic duct,
and
left hepatic duct,
Common hepatic duct,
common hepatic duct,
and the
common bile duct.
common bile duct, and this is the duodenum below. This is the duodenum coming below. Okay. So the liver is like this. These two are intrahepatic. Right hepatic and left hepatic are intrahepatic. That is, the liver is layered like this. Okay. Intrahepatic. So the within the liver, all these are extrahepatic, outside the liver. Okay. It is clear.
Clear, sir.
Okay. So type 1 is single cystic dilatation, single fusiform dilatation of the common bile duct. If this is single, right? Type 1. Clear?
Yes, sir.
Yes, sir.
Type 2 is having a small diverticulum outside, outpoaching outside. It is type 2. Type 3 is within the duodenum, there is a small diverticulum. There is a small opening, cyst here, within the duodenum. Okay? Type 4 is, it is having both intrahepatic dilatations, extrahepatic dilatations. That is type 4A, intrahepatic, extrahepatic. Type 4B is only extrahepatic, but multiple. That is the difference between type 1 and type 4. Type 5 is only type 5 is, 1 minute. Type 5 is only intrahepatic. Type 4A is both intra and extrahepatic. Type 4B is only extrahepatic but multiple. That is the difference between type 4B and type 1. Okay?
Sir, type 5 is only intrahepatic.
Only intrahepatic. Intrahepatic dilatation of the biliary tree.
Okay, sir.
Okay? Yeah. So now you can answer this question for me. What is endoscopic treatment is reserved only for only one of these, for which endoscopic treatment is possible? Out of these 5, in fact 6, endoscopic treatment is only possible for one cyst. What is that cyst?
Type 3.
Any other answer? Anybody else wants to answer?
3, sir.
2 people answered 3. Others answer something.
Type 3.
3
Okay.
only.
3. Yeah, very good. So you understood that. So endoscopic treatment is reserved only for type 3. Okay. Most common is type 1. Most common is type 1. All these are very important MCQs. So most common is type 1. No need to mug up. Just remember the biliary tree. 1 is extrahepatic single dilatation. 1. 2 is a diverticulum. 3 is into the duodenum. So endoscopic treatment is possible. 4 is a 4A, 4B. 4A is both extrahepatic, intrahepatic. 4B is extrahepatic, multiple. 5 is intrahepatic. Okay? Clear?
So most common is type 1 and
Type
endoscopy is for type 3.
Type 3. And
And any other for any other?
yeah, Caroli's disease. Caroli's disease is type 5. Other name of Caroli's disease is type 5. Okay? Central dot sign is seen in Caroli's disease. Central dot. So today we have complex 3 important signs. Chain of Lake's appearance.
Chronic pancreatitis.
Double duct sign. Double duct sign.
Pancreatic diversum.
Sorry?
Diversum.
No. Periampullary cancer. Okay? And here central dot sign. Central dot sign. Central dot sign is seen in Caroli's disease, type 5. Okay, here investigation of choice is MRCP. Management. See. Clear? Something, you got something at least with this?
Yes, sir.
Yes, sir.
Please answer yes or no. Is it clear?
Yes, sir.
Fine, sir.
Okay. So now, because there is no need to mug up, just if you understand the concept, it is easier. So treatments also, we'll see treatments and we can close it off. So this is the intrahepatic, this is the extrahepatic, common hepatic duct, cystic duct, and bile duct, duodenum. So type 1. What is the treatment for type 1? Here is the duct. It is enlarged. So tell me, whatever, even if it is wrong, it's okay. Just tell me if there is a single type 1, single duct is there, it is enlarged. So what are the possibilities? What can you do?
So it would be hepatogynostomy.
Hepaticogynostomy. Yes, you access this part of common bile duct, you access of. The remaining is hepatic duct. You anastomose it with the jejunum. Okay, so hepaticogynostomy. First, for 1, it is hepaticogynostomy. For 2, there is a small diverticulum. So what you can do? Is it necessary to remove the bile duct entirely for that small diverticulum? Yes, no?
No, we can do a myotomy. And
Yeah, we can just do a diverticulectomy and a myotomy. Diverticulectomy is enough for that. Okay, remove the diverticulum. That's all. For 3,
That would be endoscopy.
endoscopy. Very good. For 4A, 4B, and 5. 5, intrahepatic, multiple. So for
Liver?
4B, sorry.
Liver transplantation, Raphael?
Yeah. So for 4A, what is 4A?
That's intra and extra hepatic.
Intra and extra hepatic. So once if disease is going inside the liver, then our only option is to do a liver transplant, nothing else. So 4A, liver transplant. 5.
liver,
That's also intra and it's also multiple. So again, liver transplant.
Yeah, again liver transplant. For 5 also it is again liver transplant. Okay. Got it. So we are left with 4B. What is 4B?
Only extrahepatic but multiple.
Only extrahepatic but multiple. Very good. So we are having the intrahepatic, but extrahepatic completely it is gone. So what we do is we do a portoenterostomy. That is, we take the jejunum and we will anastomose directly to the liver bed. That is known as portoenterostomy. Portoenterostomy. That has a name also, Kasai. The procedure name is Kasai. Kasai's portoenterostomy. Okay. Remember this. Kasai's portoenterostomy. You understood, right? Because the entire extrahepatic tree is gone, we will remove it completely. And we will just take the bowl and we'll attach it to the liver surface, portal plate. So it is portoenterostomy. Okay? Clear?
Yes, sir.
So there is another entity called extrahepatic biliary atresia. In this, the liver is normal, but these kids are born with this extrahepatic biliary tree is not developed at all. So what is the treatment here? This is not developed at all.
Same, portoenterostomy.
Yes. Okay. Is it clear for everyone?
No, sir.
Okay. See, I'm telling you understood the treatment for type 5, right?
Yes.
Sorry, not type 5. It is type 4B. You understood the treatment for 4B?
Yes, sir.
Portoenterostomy understood. So now we are talking about extrahepatic. This is another problem. Extrahepatic biliary atresia. It is another problem. Extrahepatic biliary atresia where the liver is there. Intrahepatic portions are okay, but extrahepatic portions are atretic in these kids, newborn people. Extrahepatic, there is no drainage process, drainage only. So what you do is we will excise this completely and we'll directly anastomose the liver to the intestine. That is portoenterostomy. Is it okay now?
Okay,
Yes?
sir.
Okay. So next, hemobilia. What is hematuria? Hematuria.
Blood and urine.
Blood and urine.
Hemobilia.
Blood and bile.
Blood and bile.
Yeah. So there is a triad called Quincke's triad here. There will be jaundice, there will be upper GI bleed, and there will be pain. So this is the triad here. Diagnosis is it is bleeding. So angiography should be done. Angiography. And other entity is bulimia. Bulimia is bile in blood. That is blood in bile. This is bile in blood. A fistula will be formed between biliary tree and the vein. Okay. So it is often most trauma, and the investigation of choice is ERCP here. In hemobilia it is CT angio, and bulimia it is ERCP. This is just for completion, but just single liners, just remember this. Okay, so we completed extrahepatic biliary and gallbladder also.